Live Hospital, which promises to be the future of healthcare with its experienced patient care and guest-oriented approach, opened in Vadi Istanbul. It is that moment which makes you hold on to life, sometimes near a forest, sometimes in daily life. With its advanced diagnostic and treatment methods, that moment actually represents the future. There are some moments which makes you look to the future confidently. Those moments are the future. Live Hospital, the future of healthcare, opened in Vadi Istanbul.
В Вади, Истанбул, открылась больница будущего – Live Hospital, отличающаяся опытом в уходе за пациентами и гостеприимным подходом к своим пациентам. Порой расположение на краю леса, порой в жизни наступит момент, когда продвинутые методы диагностики и лечения помогут вам выжить. Этот момент обязательно настанет. Есть моменты, когда вы начинаете смотреть в будущее с уверенностью. Так вот, это именно этот момент будущего. В Вади, Истанбул, открылась больница будущего – Live Hospital.
MR Linac, one of the most important investments in cancer treatment in Turkey, was realized at Live Hospital. With MR Linac, an effective radiotherapy method, all treatment is done in accordance with the target. Thanks to the MRI images, the required dose is applied to the tumor with a point shot during the treatment. While there is a very rapid response to the treatment, the healthy surrounding tissues are better protected. Thus, the number of sessions is reduced and a comfort zone is created for the patient.
Hastalarımız her gün makineye geldiklerinde öncelikle nasıl bir alandan ışınlanacakları makinedeki o günkü anatomisine göre belirlenerek kişinin o günkü durumuna adapte edilmiş, uyumlandırılmış bir tedavinin önü açılmaktadır. Özellikle yumuşak dokulara çok yakın olan tümörlerin günlük olarak görülmesine ve etrafındaki normal dokuların yine çok iyi bir şekilde fark edilerek gereksiz radyasyondan kaçınılmasına yardımcı oluyor.
Good day and welcome. My name is Katerina Tikhanova. I'm from Ukraine. Me and my colleagues from different countries gathered here to help you and to give you the best medical care. Let me explain how the things are working here. First of all, we are receiving an email from you. It contains your request, all information about your disease, medical reports, MRI, X-rays, screens, etc. After that, we are sharing all that information with a certain doctor and taking his medical second opinion, which is MSO for short. The doctor prepares your own treatment plan accordingly. After that, we are taking the cost of the treatment plan from our accounting department and sending the offer to you. If you are accepting the program, from that moment you can start to prepare your plane ticket. We are also helping you with the hotel accommodation, transfers, and arranging your own translator. At your arrival day, we are meeting you with our VIP cars in the airport and bringing to the hospital. We are honored to know you as a Live Hospital family. We are ready to help you 24 hours a day, 7 days in a week. Live Hospital International Patient Service wish you a healthy days.
Здравствуйте, меня зовут Нигина Исмаилова. Я являюсь ответственным лицом по медицинским запросам в клинике ЛИВ для стран СНГ. Наша команда состоит из 40 человек. Мы занимаемся предоставлением второго медицинского мнения. Для этого пациент отправляет нам свои медицинские заключения, лабораторные исследования, если есть радиологические снимки. Специалисты клиники ЛИВ рассматривают и составляют план лечения и диагностики. Алгоритм требующихся обследований, а также их предварительная стоимость отправляется вам на почту. После того, как вы подтверждаете план диагностики и отправляете нам дату вашего приезда, мы организовываем вашу предварительную программу обследования. В случае надобности помогаем вам с резервацией отеля. Также предоставляем вам трансфер с аэропорта в аэропорт. Передаем всю вашу медицинскую информацию, отправленную вами, русскоговорящему переводчику, который будет вас сопровождать в период вашего пребывания в клинике. В день вашего приезда наши коллеги по логистике встречают вас в аэропорту и привозят в клинику ЛИВ. Сейчас вместе с вами посмотрим продолжение. Мы, как клиника ЛИВ, гордимся тем, что нам предоставилась честь узнать вас. Отныне мы являемся частью вашей семьи и готовы вам помочь круглосуточно касательно вопросов вашего здоровья. Международный отдел клиники ЛИВ желает вам благополучных дней.
Merhaba, ben Profesör Doktor Levhi Akın. 2014 yılından beri Live Hospital Ulus'tayım. Genel cerrahi ve cerrahi onkoloji uzmanıyım. Aynı zamanda Tıbbi Yürütme Kurulu üyesi olarak idari bir görev de yapmaktayım. Şimdi beraberce Live Hospital Ulus'un içine gireceğiz ve sizler için hastanenin ne kadar güvenli olduğunu gösterebilmek için birlikte bir hastane turu yapacağız. Güvenlik ünitemizi geçtikten sonra tarama bankomuza geliyoruz. Burada uzaktan ateş ölçümümüz yapılıyor. Daha sonra yakın özgeçmişimizle ilgili bir takım sorular sorularak kayda geçiriliyor. Taramamız tamamlandıktan sonra taramayı başarıyla tamamladığımıza dair yakamıza bir etiket iliştirilecek. Hastanede bulunduğumuz süre içinde bu etiketi sürekli yakamızda taşıyoruz. Buyurun. Evet, içeri girdikten sonra önce danışmaya giriyoruz. Burada görmüş olduğunuz gibi sosyal mesafe kuralları açısından gerekli önlemlerimiz alınmış durumda. Girişten itibaren sarı çizgilerimizi devam ettiğiniz zaman onkoloji hastalarımız için özel olarak tahsis edilmiş olan asansörümüze ulaşıyorsunuz. Öncelikle şunu ifade etmek istiyorum. Bizler için en önemli olan şey sizlerin ve hastane çalışanlarımızın güvenliği. Biz sizlerin sağlığı ve tedavisi için buradayız ve hizmete hazırız. Misafirlerimize açık alanlarda ve bekleme bölümlerinde bir takım tedbirler aldık. Gördüğünüz gibi sosyal mesafe kurallarına uyabilmek için işaret gördüğünüz alanlara oturulmuyor. Diğer alanlara oturuluyor. Oturulan alanlar her yarım saatte bir temizlik personeli tarafından siliniyor ve temizleniyor. Hastanemizde gerek hastalar, gerek ziyaretçiler, gerekse de refakatçilerle birlikte tüm hastane çalışanları için maske takılması zorunludur. Şimdi bir hasta muayene odasını birlikte göreceğiz. Zaten hep temiz olan yerler. Fakat bu dönemde biz bu işe daha çok konsantre olduk. Her hastadan sonra örtülerimiz zaten değişiyordu, gene değişiyor ama yüzeyler tekrar siliniyor. Sehpalar, her hastadan sonra sandalye kolları, kapı kolları, ışık düğmeleri hepsi temizleniyor. Ayrıca Türkiye'nin dört bir yanındaki hastalarımıza video klinik olarak da hizmet verebiliyoruz. Bilgisayar üzerinden kamera aracılığıyla sizler bizi görebiliyorsunuz, bizler sizi görebiliyoruz. Burada bilgisayardaki bütün sonuçlarınıza ulaşabiliyoruz. Tıpkı yüz yüze görüşüyormuş gibi sonuçlarınızı değerlendirebiliyoruz. Poliklinik hizmetlerimiz güvenli, acil servis hizmetlerimiz güvenli, tetkikleriniz güvenli, ameliyatlar güvenli. Ameliyathane güvenliği için de gerekli tedbirlerimizi aldık. Bu konuda şimdi ameliyathane sorumlumuz Profesör Doktor Didem Dal Hoca ile görüşeceğiz. Buyurun. Profesör Doktor Didem Dal'la birlikteyiz. Sayın hocam, bu süreçte ameliyatlarla ilgili ne gibi tedbirler aldık?
Bu hassas dönemde kesinlikle sağlığınızı ihmal etmeyin. Sağlığınız için gereken tetkikler, gerek bir ameliyat, herhangi bir işlem gerekiyorsa güvenle, doktorlarınıza güvenerek, hastanelerinize güvenerek gelebilirsiniz. Çünkü onlar sizler için, sizlerin güvenliği için tüm tedbirleri alıyorlar. Aynen kendi sağlıkları ve güvenlikleri gibi sizlere de her tür hizmeti sunmaya hazırlar. Bizler de bunları yapmaya çalışıyoruz.
Benimle bu hastane turuna katıldığınız için teşekkür ederim. Live Hospital Ulus'u sizler ve hastane personelimiz için mümkün olan en güvenli hale getirdiğimizi umuyoruz. Sizler için buradayız ve hizmete hazırız. Tedavilerinize devam etmek istiyoruz. Unutmayınız, güvenliyiz ve sizi de güvenli tutmak için buradayız.
Hi everyone, good morning. I'm Dr. Emre Günay. We are working as a surgery team with Professor Hasan Taşçı. So he's
Всем здравствуйте, я работаю вместе с профессором Хасан Ташчы.
he was going to make this presentation, but he's stuck in Mauritania,
Он
so
подготовил эту презентацию.
I'm going to make the presentation. We are going to talk
Я
about
буду представлять презентацию.
basic definitions and principles of the surgery
Мы
in
будем,
kidney
у меня
transplantation.
будет презентация по трансплантации почек.
It is the gold standard treatment method in end-stage renal disease. It increases the quality of life and the lifespan is prolonged. It requires a multidisciplinary approach with nephrologists, urologists, and also immunologists. It's then closely related to developments in many fields. So, better understanding of kidney physiology and function and advancements in surgical technique and drug studies are necessary. Let's talk about the history a little bit. First successful kidney transplant between identical twins made by Dr. Murray in Boston in 1954. And the recipient died 8 years later because of MI. Then in 1958, Jean Doucet discovered the HLA system. Then he received the Nobel Prize in Medicine in 1980 for this discovery. After that, in 1961, the first successful cadaveric kidney transplant was performed after the discovery of azathioprine, one of the first immunosuppressive treatments. These are the number of the transplants in Turkey between 2017 and 2020. We will talk about the kidney transplants. In 2017, there was 3,344, but then last year it decreased significantly because of the pandemic, COVID-19 pandemic. Then it's mirroring the current waiting list also. You see in 2019, kidney waiting list is 22,960. Then in 2020, it's reduced approximately 2,000. We can see the same decrease in brain death and family consent in 2020 because of the pandemic. There are some transplantation types according to the organism taken and transplanted. Autotransplantation is a transfer of tissue from the one place to another in the same organism. The examples are skin grafts, then after parathyroid resection. Isotransplantation, isograft is between the individuals of the same species, genetically identical. You will remember I taught the first transplant between identical twins. Allotransplantation is among individuals of the same species, genetically different from each other. Today, we are doing this most common And the xenograft is the among organisms of different species with different genetically structures between animals and humans. In the recent studies in the last year, the NYU Langone transplant team led by Dr. Montgomery transplanted a kidney from a genetically modified pig to a brain-dead human being to the thigh of the human being from the outside, and this kidney continued to function until all life functions of the patient ceased. Approximately more than 48 hours it worked. So there is no any manuscript written about this project, but the New York Times made a news about it. Here we see Dr. Montgomery and the operation scene. Kidney transplantation from living donor is between the relatives of the sick person from the first degree, for example, mother, father, child, and the fourth degree, uncle, aunt's child, brother's grandchild, etc. Can be the donors. Similarly, kidneys can be taken from the patient's spouse and their relatives up to the fourth degree. In addition, in Turkey, donors who are emotionally close but not related can become donors if they apply to the health directorates and get approval from the ethics committee. Persons under the age of 18 cannot be organ donors. For a person to be an organ donor, it's necessary to be a volunteer. Brain death definition is the irreversible loss of brain and brainstem functions. Despite all the medical support given in the intensive care units, after a while, other vital organs lose their functions. It's not possible for people diagnosed with brain death to return to life. A brain death decision is made as a result of joint evaluation of neurology or neurosurgery specialists together with anesthesia and reanimation specialists. Let's talk about cross and domino plants a little bit. The situation where two patients who are waiting for an organ transplant but who have incompatibility with their donors can exchange the donors is called cross transplant. Sometimes this swap can be done in 3, 4 or more. And the transmission in which the chain is extended in this way are called domino transplants. The main problem in cross and domino transplants is the criteria of donor of a candidate are more disadvantageous than the donor of the other candidate, such as the age of the candidate or the kidney functions also. Marginal donors are adults in or above 60 years old or 50 years and over, plus 2 additional risk factors like hypertension, cerebrovascular event of the cause of death, and the serum creatinine level is higher than 1.5. According to the location of the graft, there are 2 types of transplantation. One type is called orthotopic, which means the organ is placed in its original place, like lung, heart, and liver. Heterotopic is the organ is placed in a different place from its original place. For example, kidney into the iliac fossa, and the other example may be parathyroids. We are surgeons, so we are going to talk about the surgical technique more. Donor surgery is examined under two headings as cadaver and living donors. The surgical team should be very careful about vascular anatomy and variations. Damage to vascular structures or the ureter can lead to serious problems, sometimes even loss of the organ. Cadaveric donor surgery is a multidisciplinary organization. Incision extending from the sternum notch to the symphysis pubis in multi-organ excision. Aorta and portal vein cannulation first of all made. Then the infusion of cold preservation solution through cannulas, followed by placing iced water around the organs. Heart, lung, liver, and pancreas are resected in block respectively. Then the kidneys are removed in an en bloc nephroureterectomy, including the aorta and vena cava. Anatomical details, number, and location of arteries, veins, and ureters must be recorded. Of presence of the cyst or tumor is investigated. If necessary, a biopsy should be performed. Then the kidneys are placed in cold storage solutions and ice storage container respectively. It's necessary to record that is it a right or left kidney, and if it will be transferred to another center to transplant, should be recorded immediately. The storage solutions are mostly WUW or HDK solutions used. Kidneys can be transplanted within 72 hours, but after 24 hours, the rate of primary dysfunction increases. Living donor surgery, of course, has the better immunological compliance and shorter cold ischemia time. Donor nephrectomy can be done open, hand-assisted laparoscopic or hand-assisted robotic methods. Three-dimensional CT angiography is very helpful for revealing the renal anatomy. Here are some examples about the 3D CT angio images. Now we can see the renal artery coming from the aorta and the renal vein going through the vena cava inferior. In open donor nephrectomy, we are often using the retroperitoneal approach with a plank incision. Suspension of the ureter is necessary. The adrenal vein and gonadal vein are separated from the renal vein by ligating. The ureter is tied at the closest point at the part where it enters the bladder and it's cut. Following the placement of the vascular clamps, first the renal artery, then the renal vein are cut and the donor nephrectomy is completed. Kidney is cooled and prepared on the back table. Renal artery and vein stumps are closed with non-absorbable sutures. Closed system vacuum drains are also prepared as drains, like Hemovac and Jackson-Pratt drains. Laparoscopic donor nephrectomy firstly performed by Ratner in 1995. We are performing it transabdominal by 3 or 4 trachars using vascular endo-GIAs to transect the renal artery and renal vein. And after extracting the kidney from approximately a 7 centimeter fine and steel incision, in the hand-assisted laparoscopic and hand-assisted robotic method, a hand port is used and the organ is then removed from this port. Hand-assisted laparoscopic nephrectomy can be done without using a hand port. We are making approximately 8 or 8.5 centimeters incision for this. In laparoscopic donor nephrectomy, there is less analgesic requirement, shorter hospital stay, and so better cosmetic results. Professor Hasan Taşçı has a manuscript published in Transplantation Proceedings in 2019 about hand-assisted laparoscopic left donor nephrectomy without a device. Here is the basic image of the transplantation done in the iliac fossa. We are making the anastomosis to the external iliac artery and veins. This is the position of the donor. We are often using the right decubitus position. And after we are measuring under the umbilicus like 7 or 8 centimeters. Here you see the left hand in the abdomen and the right hand holding the energy device into the port. Here we see an operation photo. Here is the renal vein. Here is the adrenal vein opening to the renal vein, and there is a variation of the lumbar vein opening to the renal vein. Here is an example of the clipping of the adrenal vein and the cutting of the adrenal vein to separate from the renal vein. This is an example for the back-table kidney preparation. You see we all excise the Gerota fascia from the kidney, and one renal artery and one renal vein is here. Graft loss due to technical reasons is very rare in the recipient surgery. Generally, the right iliac fossa is preferred because it provides the technical convenience. The external iliac artery and vein are more superficial in this area. If pancreas transplantation is to be performed together, the left side is preferred. With an oblique incision in the right inguinal region, then the musculoaponeurotic layer is passed and the retroperitoneum is entered by medialization of the retroperitoneum. By preserving the lymphatic structures, the artery and vein are prepared and suspended by turning. The external iliac artery and vein are usually used for anastomosis. And if there is a double artery, it can be made into a single artery, or anastomosis can be made separately. We are often using 5-0 or 6-0 polypropylene sutures to make this anastomosis. First the vein and then the artery anastomoses are performed, and after both anastomoses are finished, the vascular columns are removed in the same order. Ureteral anastomosis is performed with continuous or individually absorbable sutures like the artery and vein anastomosis, but we are using mostly PDS sutures in here. We are making this anastomosis mucosa to mucosa, and the muscular layer is sutured and tunneled to prevent the reflux. In order to prevent urine leakage and ureteroneocystostomy stenosis, a transanastomotic double G stent from the renal pelvis to the bladder is placed, and then we remove it approximately 6 or 8 weeks after the operation. Then, like the donor surgery, we are using closed system vacuum drains like Hemovac or Jetson Prets. This is the photo of the recipient operation. It's the normal supine position. Here is some photo of renal artery anastomosis. And this is the renal vein anastomosis just before the opening. Then again, renal artery and vein anastomosis finished, and the kidney is perfused in here. Here is the variation of double renal artery anastomosis made separately to the external iliac artery. There is another example of the separate anastomosis. Accessory renal arteries are common and present in 25% of the population, and it sometimes can be bilateral, about 10%. The term of extrarenal artery may be used with two subclassifications. Aberrant renal artery means there is another one supplying the superior or inferior pole of the kidney. Accessory renal artery is supplying the renal hilum. We often see these accessory renal arteries when we were preparing the donor for the transplantation. Most common accessory renal arteries arise from the abdominal aorta. Here we see a double ureter variation. In this case, we made a single mouth of both ureters, and in both we put double G stents and then perform the anastomosis to the bladder. Duplicated ureter is the most common renal abnormality occurring in approximately 1% of the population. Now we are going to talk about the surgical complications a little bit. We don't have much time, I think. Wound site separation, for example, eventration or evisceration can be seen. Eventration can be managed conservative, but evisceration should be managed surgically. Wound site infections can be seen. Drainage should be necessary, and culture and appropriate antibiotics should be given. Serious bleeding for the technical reasons is very rare. Bleeding usually occurs from ligated venous branches. Very rarely, it may be secondary to renal rupture due to hyperacute rejection. Early intervention is important in severe bleeding requiring surgical intervention. Bleeding occurs mostly in the retroperitoneal area. In this situation, correction of coagulopathy and conservative approach may be sufficient. Bleeding complications can be significantly reduced by good dialysis in the pre-transplant period and controlling the bleeding parameters. Using of ASA and other anticoagulant drugs should be stopped about a week ago. In early bleeding, blood transfusions can be performed using irradiated erythrocyte suspensions and leukocyte filters. Vascular thrombosis can be secondary to surgical technique or acute rejection. The classic symptom is sudden cessation of urination. It can be surgically corrected in the early period. It results about 1% of graft loss in cases. If the renal artery stenosis is detected, It's a generally late period complication. It can also be seen in the first 2 months due to improper surgical technique. Clinical findings are murmur on the graft dysfunction, repeating attacks of hypertension. Doppler ultrasonography and angiography can be used in diagnosis, and the treatment options are endovascular interventions and surgery. Lymphocell develops secondary to damage to the lymphatic vessels around the external iliac artery and vein. It can cause hydronephrosis by compressing renal pelvis, and the ureter. Urine leakage and seroma should be considered in the differential diagnosis. Sampling of the fluid guides to the diagnosis. In the treatment, lymphocell is opened to the peritoneum by open or laparoscopic method called fenestration. Urine leakage can be happen by ureteric ischemia or ureteroneocystostomy leakage. It's confused with rejection due to abrupt cessation of urine, suspected by an increase in the amount coming into the drain and confirmed by the laboratory tests. It can be remain conservative. Ureteroneocystostomy revision may be required. If ureteral ischemia has developed, repair with a Boyer flap may be required. Here's an image showing the basic Boyer flap technique. It's simply a flap taken from the bladder, and we are making it in a tube form, then wrapping it around the undamaged ureter, and then it's finished. Ureteroneocystostomy stenosis or occlusion is the late complication, usually secondary to ischemia. After removal of the ureteral stent in the early period, pelvic cholectasia and post-renal acute kidney failure in the graft, we can see hydroureteronephrosis, and we can treat it by minimally invasive methods or surgery. Graft nephrectomy is indicated in cases of graft loss due to hyperacute or acute rejection, or if systemic symptoms develop after graft loss due to chronic rejection. Anatomical structures can be identified in the early period, but it can become an extremely difficult procedure in the late period. Therefore, subcapsular nephrectomy may be necessary. Without revealing the anatomical structures, it progresses through the capsule, and the vascular structures in the hilum are taken under control. Thus, iliac blood vessels are preserved. Thank you for your patience. Now, sorry. Are we going to take the questions now or after all the presentations finished? No. I'll share. Stop sharing.
Article is robotic assisted transplantation. I'm a urologist. Kidney transplantation surgery, minimally surgical methods are routinely performed for donor nephrectomy. One is laparoscopy and the other is robot assistance. What about renal resection? Until recently, open surgery was the only option. Disadvantages of open surgery. All of the world knows that size of incision, wound, space infection, postoperative more pain, longer convalescence time, working in a narrow retroperitoneal space. Advantages of laparoscopy: small incision, less pain, less apoptosis, less response, less infection, early discharge, cognitive, early return to normal life, faster convalescence, and decrease in morbidity. Robotic surgery advantages: high definition, 3D visualization, full articulated instruments, corrections for tremors, enhanced movement, greater precision, hand-eye coordination, easiness of suturing, easiness of hemostasis, advantage of three are working comfortably in narrow spaces. Robotic kidney transplantation history first reported 2002 in France. The recipient was undergoing a second transplant using cadaveric kidney, operating time 178 minutes. Vascular anesthesia was performed in 7 minutes. Immediate graft function was achieved. Further development didn't occur till 2009. First reported full robotic kidney transplantation of 3 years. Only obese patients they performed. The other is 2014. PCA reported their experience with 10 patients, but this study, the kidney was placed the replicating through Gibson incision, and they performed open surgery, but anastomosis and the other replace implantation is robotic. Then we look at the publications. There was only one person whose name is Dr. Alabat. They performed, he and team performed robotic transplantation a lot from India. This study is 54 robotic transplantation, and they development of the technique. So I went to Dr. Alabat to India, and I learned robotic transplantation, and he helped me. This is a position, robotic transplantation position. This is a port placement, you can see. This is a robotic docking. Yeah, this is a vascular bed preparation. You can see robotic arms. The right side is the scissors, and the left side is bipolar. You can see the external, the right side external iliac artery and external iliac vein. This is the external iliac vein. Then we, after we prepare the vessels, then we prepare the bladders to, after the operation, we anastomosis the ureter, into the bladder. This is a rapid kidney in iceberg. You can see on the table. We covered the eyes of, in kidney, then covered the dance. Now we insert the kidney button. Now we insert the bulldog, and first of all, we are cutting the external iliac vein. Then we start the renal vein and external iliac vein anastomosis. You can see. The control of the bleeding after the vein anastomosis, we start the arterial anastomosis. The program. Okay. After the arterial anastomosis, we pass the other video. Then extraperitoneal, after the extraperitoneal, the kidney, then ureteronephrostomy is started. After the ureteronephrostomy, we finish the kidney transplantation. After the operation, you can see the incision of the patient. The right side, the robotic transplantation. The left side, the open surgery. This is the third publication, robotic kidney transplantation. The 15 cases we reported, only palliative first cases, palliative used 2 patients. Because of the, we don't know how we use the eyes. After that, we never see. The other publication is robotic kidney transplantation comparison of the 40 cases open and robotic kidney transplantation. It was publication in British Journal of Urology. When we compare the open and robotic kidney transplantation, there isn't any statistical difference between functional results, but when we look at the pain, VAS score is statistically less in robotic kidney transplantation, and two lymphocytes we saw the open surgery, but we never seen robotic kidney transplantation. Then after the robotic kidney transplantation, the European working group was published European Urology, Robotic Kidney Transplantation, the European Experience. And robotic kidney transplantation is a safe and applicable method when performed by surgeons who are experienced in robotic surgery and kidney transplantation. The other working group, and I'm also here, 148 robotic kidney transplantation and multiple kidney vessels, 21, and 127 single artery and vein implants. So no difference about vascular anatomy this time, and at multivariable analysis, multiple vessels was not significantly associated with optimal renal function at post-operative transplant. This is a Dr. Alavat and I published learning curve and timing of surgical robotic kidney transplantation with regional hypothermia. The result is for the surgeon's experience with open transplant and robotic surgery for other procedures, the learning curve of robotic kidney transplantation is short, with improving still up to 20-25 cases. And the other publication, European experience of robotic kidney transplantation, minimum 1 year follow-up, long-term complications, one urethral stricture, one grade pyrometric, and robotic kidney transplantation was associated with low complication rate, and there was a maintenance of excellent graft survival and functional with a minimum follow-up 1 year. You can see the publications, all of them, I and my team. So far, we have performed 115 robotic kidney transplantations. Thank you for the attention.
Live Hospital, which promises to be the future of healthcare with its experienced patient care and guest-oriented approach, opened in Vadi Istanbul. It is that moment which makes you hold on to life, sometimes near a forest, sometimes in daily life. With its advanced diagnostic and treatment methods, that moment actually represents the future. There are some moments which makes you look to the future confidently. Those moments are the future. Live Hospital, the future of healthcare, opened in Vadi Istanbul.
В Вади Истанбул открылась больница будущего Live Hospital, отличающаяся опытом в уходе за пациентами и гостеприимным подходом к своим пациентам. Порой расположение на краю леса, порой в жизни наступит момент, когда продвинутые методы диагностики и лечения помогут вам выжить. Этот момент обязательно настанет. Есть моменты, когда вы начинаете смотреть в будущее с уверенностью. Так вот, это именно этот момент будущего. В Вади Истанбул открылась больница будущего Live Hospital.
MR Linak, one of the most important investments in cancer treatment in Turkey, was realized at Live Hospital. With MR Linak, an effective radiotherapy method, all treatment is done in accordance with the target. Thanks to the MRI images, the required dose is applied to the tumor with a point shot during the treatment. While there is a very rapid response to the treatment, the healthy surrounding tissues are better protected. Thus, the number of sessions is reduced and a comfort zone is created for the patient.
Hastalarımız her gün makineye geldiklerinde öncelikle nasıl bir alandan ışınlanacakları makinedeki o günkü anatomisine göre belirlenerek kişinin o günkü durumuna adapte edilmiş, uyumlandırılmış bir tedavinin önü açılmaktadır. Özellikle yumuşak dokulara çok yakın olan tümörlerin günlük olarak görülmesine ve etrafındaki normal dokuların yine çok iyi bir şekilde fark edilerek gereksiz radyasyondan kaçınılmasına yardımcı oluyor.
Good day and welcome. My name is Katerina Tikhanova. I'm from Ukraine. Me and my colleagues from different countries gathered here to help you and to give you the best medical care. Let me explain how the things are working here. First of all, we are receiving an email from you. It contains your request, all information about your disease, medical reports, MRI, X-rays, screens, etc. After that, we are sharing all that information with a certain doctor and
Yani bir şey olmadı ki, almadı ki. İki aslında. Ekranı niye kapandı? Tamam, şu ekran kapandı. Dear participants, welcome to the meeting. After this presentation, I will share you patient selection. Chronic kidney disease is a common condition in the community. It ranks 10th among causes of death. It is defined as structural or functional impairment in the kidney lasting longer than 3 and 6 months with or without a decrease in glomerular filtration rate. This damage can be detected by urine, blood, or imaging methods. Thereafter, chronic kidney failure starts. There are 5 stages of illness. Glomerular filtration is normal, stage 1. When there are signs of kidney damage in stage 1. In the second stage, the glomerular filtration rate is between 60 and 89. In the third stage, the glomerular filtration rate between 30 and 59. And finally, stage 5 is called end-stage renal disease. The prevalence of chronic kidney disease in the United States is 14.5. In Turkey, the prevalence of the disease was found to be 15.7. Okay. It has been determined that 1 out of every 6 and 7 adults has kidney disease of different stage. Okay. On this slide, you can see the distribution of the patient according to the stage. The patients accumulated the first stage of chronic kidney disease. It is estimated that there are approximately 2.3 million patients in the last 3 stages in Turkey. The incidence of end-stage renal disease typically increase each year. In 2020, approximately 140,000 new patients with end-stage renal disease were observed in the United States. Similarly, the prevalence of end-stage renal disease in the country is increasing every year. In total, there are 850,000 patients with end-stage kidney disease in the United States of America. In the Turkey, while the total number of end-stage renal disease patients was 83,000 in 2020, the number of new patients was 11,500, while approximately 1,000 patients per million were in the last period. Despite this fact, awareness of chronic kidney disease is very low. You see that the awareness in the first 3 stages is below 15%. It's very bad condition. The 5th stage is the stage in which one of the renal replacement therapy should be initiated. These treatments are kidney transplantation and dialysis. The originator of hemodialysis is Graham. In 1943, Koch applied the first hemodialysis treatment in humans by wrapping a cellulose tube around a cylindrical drum and turning it into a container with dialysis solution. The first hemodialysis in Turkey in 1962. Hemodialysis is extracorporeal therapy. There are very restriction for hemodialysis patient. A vascular access route is needed for this therapy. The other hand, renal transplantation experiment is in 1902, the first successful experimental kidney transplant were performed at Vienna Medical School in Austria with animals. In 1999, the first kidney transplant experiments were performed in humans in France using animal kidneys. And then in 1933, the first human-to-human kidney transplant was performed, but the donor kidney never functioned. And finally, the first successful kidney transplant is performed by Harrison and Joseph Murray in 1954. In Turkey, kidney transplant from living donor was performed in 1975 by Mehmet Haberal. The most common type of replacement is hemodialysis. The second type of replacement is kidney transplantation, and the third type of replacement is peritoneal dialysis. In Turkey, also the most common type of replacement is hemodialysis, with 73%, and kidney transplantation is the second place. After this information, I want to focus on its importance. Why the gold standard replacement is kidney transplantation. What are the advantages? What are the effects of replacement types on mortality, morbidity, and life comfort? As you can see, the replacement type with the lowest hospitalization rate in kidney transplantation. This fact has not changed for many years. Compare it to the others, the type of replacement with the lowest hospital stay in kidney transplantation. You can see that the type of replacement with the lowest incidence of cardiovascular disease in kidney transplantation. Likewise, the frequency of heart failure is seen at least in the kidney transplant group. Mortality is very low in the renal transplant group. You see. Cardiovascular mortality in kidney transplantation is lower than in the hemodialysis group. It's more important that mortality after 65 years of age in the transplant group was the same as in the general population. It can be seen in this table that transplant patients are more advantageous than dialysis. Looking at the donor search, you can see that graft survival is higher in living donors in all years. Living donors are also more advantageous in terms of patient survival. In summary, the incidence of chronic kidney disease is increasing every year. Awareness rate is chronic kidney disease is very low. The most important causes of chronic kidney disease are diabetes and hypertension. The incidence of mortality and morbidity increases as the stage progresses in the patients with chronic kidney disease. End-stage renal disease needs for renal replacement therapy. Kidney transplantation is the gold standard type of renal replacement therapy. Why? More liberal diet and fruit consumption, longer survival, lower cardiovascular problems, lower hospitalization requirement, shorter stay at the hospital, less drug use requirement, higher living comfort. Kidney transplantation should be strongly considered for all patients with chronic and end-stage renal failure who are medically stable. A successful kidney transplant offers enhanced quality and duration of life and is more effective medically and economically than long-term dialysis therapy. Transplantation is the renal replacement modality of choice for patients with diabetic nephropathy and pediatric patients. A number of diseases are capable of destroying kidney function in all age groups. The most common causes of renal disease leading to kidney transplantation are the following: diabetes, chronic glomerulonephritis, polycystic kidney disease, nephrosclerosis, systemic lupus erythematosus, and interstitial nephritis. Understanding the etiology of kidney disease is important because the primary renal pathology may influence the outcome with respect to the propensity for recurrence of disease and the association of comorbidities. Pre-existing comorbid conditions in transplant candidates with renal disease may include the following: hematological abnormalities, upper and lower gastrointestinal tract abnormalities, hepatic abnormalities, cardiovascular abnormalities. The cardiovascular system is profoundly affected in patients with chronic or end-stage renal failure. The increased mortality is related to hypertension, atherosclerotic heart disease, and myocardial infarction, congestive heart failure, and left ventricular hypertrophy. Bone and joint disease, this is common in this patient because of low calcium levels, high phosphorus concentration, and elevated serum parathyroid hormone levels. Diagnosis procedures. A complete cardiac workup, including angiography, is not necessary in every transplant candidate, but patients with a significant history, symptoms, type 1 diabetes, or hypertensive renal disease should undergo a thorough evaluation to rule out significant coronary artery disease. The following procedures are indicated: electrocardiography, chest radiography, exercise and diperitomal thallium scintigraphy, echocardiography, and if indicated, coronary angiography. Special procedures may be indicated in selected patient on the basis of findings revealed in the history and physical examination as follows: upper gastrointestinal endoscopy, colonoscopy, ultrasonography of natal kidneys, peripheral artery Doppler studies, pulmonary function tests, carotid studies, avoiding cystoscopy, aerodynamic pressure flow studies. Laboratory studies in transplant candidates, blood chemistry, liver function test, complete blood count, and coagulation profile. An infectious profile should indicate the following: hepatitis B and C serology, Epstein-Barr virus, stomatitis, varicella zoster virus, a rapid plasma reagent test for syphilis, HIV, PPD, urine analysis, urine culture, and stospin should be ordered when indicated. Immunologic evaluation. Recipient of kidney transplants undergo an extensive immunologic evaluation that primarily serves to avoid transplants that are at risk for antibody-mediated hyperacute rejection. The immunologic evaluation consists of the following four components: ABO blood group determination, human leukocyte antigen typing, serum screening for antibody to human leukocyte antigen phenotypes, and cross-matching. Pre-transplant surgical interventions, the medical workup may reveal circumstances that necessitate surgery intervention to prepare the patient for kidney transplantation, native kidney nephrectomy or nephrorectomy if a patient has large polycystic kidney, significant proteinuria, or chronic reflux disease. If a patient has gallstone, cholecystectomy can need. A splenectomy may be indicated for ABO incompatible kidney transplantation, but after rituximab, it's not needed for this indication. What is the absolute contraindication for recipient? Reversible kidney disease, presence of unable to control cancer, active infections, acute hepatitis, advanced chronic hepatitis or cirrhosis, presence of anti-glomerular basal membrane antibodies in blood, recent myocardial infarction or untreated ischemic heart disease, advanced cardiac failure, advanced pulmonary insufficiency, general condition disorders that cannot tolerate major surgery, expected survival less than 2 years, lymphocyte cross-match positivity, uncontrolled psychiatric illness, active substance abuse, serious non-adherence to treatment is absolute contraindication for transplantation. What say the guidelines? For DOCI guidelines, more important for us, age, patient age alone is not obstacle to kidney transplantation. The guideline recommended not excluding patients from kidney transplantation because of age alone. Psychosocial assessment is more important for candidates. Guideline recommend not transplantation patients with an unstable psychiatric disorder that affects decision making or puts the candidate at an unacceptable level of post-transplant risk. Non-adherence is more important also these candidates, particularly to immunosuppressive medication, contributes to premature allograft loss with associated morbidity and mortality. Obesity, the other important issue. Guidelines recommended candidates to have their body habitus examined by a transplant surgeon at the time of evaluation and while on the waiting list. Patient shouldn't be excluded from kidney transplantation therapy because of the obesity. Incentive and treatment planning should be done for weight loss before transplantation. While obesity is associated with lower risk of death among patients on maintenance dialysis, despite the independent association with cardiovascular disease, the impact of obesity on transplantation outcomes is complex. Despite the survival advantage of transplantation when compared with remaining on dialysis, obesity also correlated with poorer outcomes post-transplant. Patients with obesity have a higher risk of death, delayed graft function, rejection, wound complication, and prolonged hospitalization stays compared with those without obesity. Thus, obesity remains an important issue for potential transplant candidates. Frailty is a other major issue. Guidelines suggest that candidates be assessed for frailty at the time of evaluation and while on the wait list in inform post-transplant risk and enable optimization strategies such as preoperative rehabilitation. Some types of nephritis can recur in the transplant kidney. The type of nephritis with the highest potential for recurrence is primary FHGC. Membranous nephropathy, the other recurrence glomerulonephrit in transplant kidney, but membranous nephropathy is not a reason for excluding for transplantation. Similarly, membranoproliferative glomerulonephrit and C3 glomerulopathy is not required exclusion of patient from preparation for transplantation. The patients should be screened for secondary causes and the risk of recurrence should be started with the patient. Hemolytic uremic syndrome, the other illness, it can be a recurrence in transplanted kidney, but hemolytic uremic syndrome can not exclude the transplantation. Patients with abnormal complement regulation have a high risk of recurrence, and transplantation should not be stated without the use of a complement inhibitor, eculizumab. Another important issue, pre-transplant cancer presence and cancer screening. The guideline recommend candidates undergo routine cancer screening as per local guidelines for the general population. It suggests chest CT for current or former heavy tobacco user as per local guideline, and chest radiography for other candidates. Also, guideline recommend that candidates with active malignancy be excluded from kidney transplantation, except for those with indolent and high-grade cancer, such as prostate cancer, non-melanoma skin cancer, and incidentally detected renal tumors less than 1 centimeter in maximum diameter. You see cancer type and recommended minimum waiting times after remission for kidney transplantation. It is recommended that inactivated vaccination can be completed before transplantation. If there is a live vaccine application, the transplantation should be postponed for 4 weeks. After this information, I want to tell you what are we doing. We initiated transplantation preparation processes for chronic kidney disease patient with glomerular filtration rate less than 20 milliliters minute. We are considering that optimal timing is stage 5 for kidney transplantation. We ensure that there is no contraindication to transplant for both and donor and recipient. We determine immunological risk between donor and recipient. We decide appropriate desensitization, induction, maintenance immunosuppression therapy according to the immunological risk. We close and finally we close follow-up for postoperative early and late complication. What the KDIGO say for kidney transplantation candidates? KDIGO, kidney disease improving global outcomes. Clinical practice guideline on the evaluation and management of candidates for kidney transplantation. It's publicated on April 2020. The guideline recommends that all patients with chronic kidney disease, stage 4 and 5, who are expected to reach end-stage kidney disease, be informed of, educated about, and considered for kidney transplantation, regardless of socioeconomic status, sex, gender, or race, ethnicity. The guidelines advise to refer potential kidney transplant candidates for evaluation at least 6 to 12 months before anticipate dialysis initiation to facilitate identification workup of living donors and plan for possible preemptive transplantation. Refer potential candidates already on dialysis when medically stable and kidney failure deemed irreversible. The guideline recommend not referring patient for kidney alone transplantation evaluation with the following conditions. 1, multiple myeloma, light chain deposition disease or heavy chain deposition disease, unless they have received a potentially curative treatment regime and are in stable remission. AL amyloidosis with significant extrarenal involvement. The other reason, decompensated cirrhosis, considered for combined liver and kidney transplant. severe irreversible obstructive or restrictive lung disease, severe uncontrollable and symptomatical cardiac disease, correctable and symptomatical cardiac disease, and progressive central neurodegenerative disease. Guideline recommended delaying transplant evaluation in patients with the following conditions until properly managed: and unstable psychiatric disorder, ongoing substance use disorder that affects decision making, ongoing having compromising non-adherent behavior despite education and adherence, active malignancy expect for those with indolent and low-grade cancer such as prostate cancer, and incidentally detective renal tumors less than 1 centimeter in maximum diameter, active symptomatic cardiac disease, for instance, angina, arrhythmia, heart failure, valvular heart disease that has not been evaluated by a cardiologist, active symptomatic peripheral arterial disease, recent stroke or transient ischemic attack, active symptomatic peptic ulcus, diverticulitis, acute pancreatitis, gallstone, gallbladder disease, inflammatory bowel disease, acute hepatitis, and severe hyperparathyroidism. Preemptive transplantation. Guideline recommended preemptive transplantation with a living kidney donor as the preferred treatment for transplant-eligible chronic kidney disease patients. The guideline advised that preparation can be started. Glomerular filtration rate is less than 10 milliliter minute. Summarize, kidney transplantation improves survival and quality of life and is less costly compared to dialysis. Patients with advanced chronic kidney disease who are expected to reach end-stage kidney disease have the right to be informed of all available treatment options, including transplantation. Demand for transplantable kidneys exceed supply, and thus candidacy for deceased donor transplantation needs careful evaluation. Preemptive transplantation is the preferred treatment option. Thank you for your attention.